Hi, I'm Tarek Sawas, an advanced endoscopist and the program director of the Advanced Endoscopy Fellowship at the University of Texas Southwestern in Dallas, Texas. On behalf of myself and my co-authors, I would like to thank the GIE editorial board for the opportunity to present our paper entitled Next Generation Sequencing Improves the Detection of Malignant Biliary Strictures and Changes Management. Malignant biliary strictures can be challenging to diagnose. This is primarily due to the poor performance of traditional pathology testing. When we evaluate a patient with biliary stricture during ERCP, we traditionally perform brushing for cytology and biopsy for pathology. Unfortunately, both have poor sensitivity. It's not uncommon for a patient to undergo multiple ERCPs until a diagnosis is reached. This prolonged process creates significant anxiety for patients and delay care. To enhance sensitivity, additional testing methods have been utilized, such as fluorescence in situ, hybridization, FISH, and next-generation sequencing, NGS. Our center has been using NGS for approximately 5 years. We use a panel called biliary. It is designed to analyze genomic alternation in oncogene and tumor suppressor gene associated with bile duct stricture. We collect samples in one of two ways. First, before we inject any contrast, at the initial cannulation, we collect bile and send it for testing, or we brush the stricture and send it for biliary. The performance of biliary has been shown to be very promising in the prior studies. The aim of our current study is to assess the clinical utility and the impact on patient care by using biliary. We performed a retrospective cohort study including 77 consecutive patients with biliary stricture and at least 6 months of follow-up. 28 patients had malignant biliary stricture and 49 had benign strictures. The standard cytology and biopsy combination had a sensitivity of 42.9%. On the other hand, biliary alone had a sensitivity of 75%. When biliary was combined with standard pathology testing, cytology and brushing, the sensitivity improved to 85.7%. The most important aspect of the test is the positive predictive value and the negative predictive value. The combination of biliary and pathology testing had a positive predictive value of 92.3% and an MPV of 92.2%. This meant that if a test result was positive, the likelihood of false positive was very low, and a physician was able to confidently base their clinical judgment based on biliary. Similarly, a negative result provided strong reassurance for physician and patient that the test was really negative and not falsely negative. We then investigated the clinical utility of biliary and how it affected clinical management. Among the 28 patients with malignant biliary stricture, the majority, 16 patients or 57%, had negative pathology. Biliary identified high-risk mutation in 12 out of these 16 cases, 75%, allowing for appropriate treatment, including surgery, liver transplant, chemotherapy, or hospice care as clinically appropriate. Among the 49 patients with benign strictures, all had negative pathology. Biliary was also negative in 47 out of the 49 patients, 95.9%, providing reassurance to both patients and physicians. In conclusion, our study demonstrates that by integrating NGS in routine practice for bile duct stricture, we can enhance diagnostic accuracy, minimize delay in patient care, and ultimately improve patient outcome. Again, I would like to thank the GIE for the opportunity to present our research, and please check our paper on the website. Thank you.